Welcome back to the Rethink It podcast. In this episode, we are going to rethink or maybe disrupt your thinking about how we manage anxiety and other mental health issues. I am so excited to be joined today by another medical colleague, Nicole Lamberson, a PA, who personally experienced the effects of being medicated for anxiety. Her experience will absolutely give you pause when it comes to passively accepting the standard medical therapies offered for common experiences of grief, depression, and anxiety, maybe even brain fog, maybe even fatigue. It might be news to you that many of those medications commonly prescribed for this issue can lead to serious long-term issues with the nervous system and brain function. Although we do have a good deal of research demonstrating the negative impact of these drugs, we are yet to fully appreciate the long-term brain health risks. There's this quiet pandemic going on of over-prescribing when it comes to psychiatric medications. My biggest concern, and I mentioned it in this podcast, is that we're prescribing the medications to younger and younger patients whose brains are not yet fully developed. I want you to look at just a few statistics. Number one, did you know that almost 10%, actually it's a known 10% of children are being prescribed an antipsychotic medication? So that's sort of a group category of a bunch of different drugs. A third of children ages 12 to 18 are on antidepressants. That's 33% of the children out there in the high schools are on an antidepressant. And 43% of young adults ages 19 to 21, remember the brain's not developed to 25, are on those same antidepressants. That's almost half. That's a lot of prescriptions of antidepressants. Did you know that antidepressant prescriptions have increased 35% in the last 6 years and that 8.6 million patients are currently on them? Did you know that 19% of the population has been diagnosed with anxiety and has been prescribed medications for it? And most importantly, did you know that most prescribing providers have not been trained to safely withdraw a patient from these medications? And that the risk of rapid, uncontrolled withdrawal can lead to severe, life-threatening side effects. That's a really important point that we talk about in this podcast. So in this episode, we are going to talk about some of the common experiences that patients have when they are being prescribed antipsychotics, antidepressants, anti-anxiety medications. We're going to discuss the challenges around even identifying the real cause of ongoing mental health challenges, namely prescriptions. The best part of this episode is that we will be providing a host of resources for you. Of course, they're always going to be in the show notes. If you're on our mailing, you're going to get an email with all the links directly to your inbox. So make sure that you check our website, beyondbrainhealth.com, and subscribe to the newsletter so you can get those resources directly to your inbox and put a star on them or remember them if you need them. So our guest, Nicole, is a physician assistant residing in Virginia, and she practiced in urgent care and occupational medicine until a severe illness from benzodiazepine withdrawal syndrome left her unable to work. One of the highlights of this episode is the abundance of resources that we're going to offer you and that we offer to help people struggling with symptoms related to the overprescribing of psychiatric medications. So make sure to tune in. In 2005, Nicole was prescribed Xanax for work-related stress. And over the course of 5 years, she developed many classic symptoms of benzodiazepine tolerance, including interdose withdrawal, and we'll talk about what that is. And she ultimately saw multiple psychiatrics and was misdiagnosed with mental illness. This resulted in being prescribed sort of a polypharmacy basket of medications to treat the troubling symptoms of tolerance, including 2 benzodiazepines. She was on a Z drug, a stimulant, an antidepressant, and an antipsychotic. We do talk a little bit about those categories of drugs a little bit in the podcast, so if you don't know what those are, we'll talk about that and help you demystify that a bit. But in late 2010, after discovering a magazine article, it was an article that was written by a journalist who had a similar experience with his prescribed benzodiazepine prescription. She was prompted to research further and made the connection between her own troubling symptoms and the medications. And this followed by her immediate decision to withdraw. So in hopes of receiving professional support to safely withdraw from the myriad of medications that she was on, she entered a detox center. But unfortunately, this led her to be negligently cold turkey removed from the medication. So she was rapidly withdrawn from all of them. And that's the not preferred way to do it. The preferred way would be a slow, safe taper dose. And we will talk about that as well. So tune in. You're going to get a lot of information from this podcast. Ultimately, the result of her cold turkey withdrawal was that she had severe protracted withdrawal symptoms that persist to this day. This experience really motivated Nicole to co-found what is called the Withdrawal Project. The link will be in the bio. And it's a living library of some of the most responsible, risk-reducing ways to taper off and heal from the effects of psychiatric drugs. She serves on the medical board, advisory board for the Benzodiazepine Information Coalition, and is a founding member of the Benzodiazepine Action Work Group of the Colorado Consortium. And she's an associate of the International Institute of Psychiatric Drug Withdrawal. So she's put her experience to good use for the benefit of others. As many of our guests often do, you might see a theme of that people have gone through a hard time and now they're blessing the world with their experience, hoping to help others through that process. So Nicole is head of marketing, distribution, and outreach for a documentary that I would really encourage you guys to watch. It's called Medicating Normal. It was seen on PBS several years ago, and she hosts a series of Facebook Lives, which helps gain extensive. She used that experience to gain extensive knowledge from interviewing dozens of people who are both experts in the field of psychiatry and also survivors. So she is just very well-rounded in this area. Nicole currently serves on the American Society of Addiction Medicine's patient panel, and that's advising on the development of a clinical practice guideline on the safe tapering of benzodiazepines, which we're hoping the FDA will approve. So in addition to participating in the research, some of which is ongoing, she writes and appears on podcasts and other outlets like this to share her story and educate people like you on these critical issues. So I am very excited to have her on today. I hope you guys enjoy this podcast, and thanks for joining us. Well, Nicole, I'm so excited to have you here on the Rethink It podcast with me. This topic is absolutely a topic that we need to rethink. It demands patient and practitioners alike to rethink how we approach stress, grief, mental health, all of it. So I'm just thrilled to connect with you and share the work that you're doing with our audience. Can you start by sharing a little bit about your story and how you started this advocacy work that you're doing now?
Sure. Thanks so much for having me. So whenever somebody asks me to tell my story, I'm like, oh my gosh, it's so long, but I'll try to make it shorter so that we can just kind of get to the point. But back in the 2000s, the early 2000s, I had graduated from PA school, and I was in my mid-20s at the time, so young for starting a career like that. And like most people who are starting a new job, I had stress. I was having a bad day at work. I had started this new job straight out of PA school, and I think I probably wasn't taking the best care of my body. I think that's a whole topic in itself, like what we teach young people about health and like how to care for yourself.
We don't.
Exactly. What we don't teach.
Yeah. Right. Yeah.
And just, eating the Atkins diet, which I really didn't need to be dieting, and all of that aspartame, I think at the time was not helping.
Oh, wow.
And so I accepted a prescription from one of the physicians that I worked for in the practice where I was just starting out. And he was like, oh, you don't need to go home, you know, because I had asked to leave. I felt really bad that day. And he said, oh, it's just stress, you know, take this Xanax. It'll help you with stress. And I don't know about you, but looking back in my PA training, I didn't have any information about benzodiazepines, specifically about the risk of physical dependence and withdrawal syndromes. I mean, I knew they could cause seizures.
Right. All I knew was that it was like, oh my gosh, when you withdraw from these things, like these are serious. You seriously have to pay attention. I remember categorizing it sort of with alcohol, like if you withdraw too quickly, you're going to have a seizure and you need to do it in a hospital, like or something like that. But that's about it. I didn't really know about dependence at all.
Yeah,
it was definitely something that was like, this is what we have for anxiety. And
no training or technical details on like, okay, if you get someone physically dependent on these, like here's how you get them off, you know, slowly over many months to years. They need to taper in you know, stepwise fashion. And like you, we can talk about language because I think that's a huge part of what's happening and why this is causing so many problems. Is I had them in this box of, you know, if you read the label back then, it's since been updated by the FDA, but may cause addiction.
Right.
And so I thought to myself, well, I'm not abusing them. I'm taking them as prescribed. The doctor's giving them to me. So that's not relevant to me. Right. You know, I didn't understand what physical dependence was, that you were at risk for it just by exposing your body to the substance in a prescribed way every day.
Right. Well, prescription kind of gives you a false sense of safety. Like a medically trained provider just gave me something that they understand. They've learned all about it, right? I should trust this, so it's safe. It's a prescribed substance. It's a false sense.
Yeah,
security.
Totally. And, you know, I had just graduated PA school and I was like proud of my profession and thought like PAs and doctors and nurse practitioners and medical people, like we only help. We want to help people. I had a physician for a dad and, you know, girls and your dad, he's like your hero, you know? Yep. And I thought doctors are gods, they exact cures, you know? And so I think my thinking, I was so naive, you know, and just fresh and new. So I started within a couple of months. In hindsight, I didn't understand at the time what was happening. I started developing adverse drug effects, which are classic for benzodiazepines, which is like interdose withdrawal and tolerance type problems.
What's the interdose withdrawal? Just to kind of demystify that. And I mean, I think some people might pick it up, but maybe it's just language that somebody's never heard before.
Okay. And it's good to explain it because if someone else is having it, maybe you can recognize it sooner than I did. But basically, especially with short-acting benzos, but even the long-acting ones, you know, your body, as soon as you start ingesting the chemical, is trying to find a workaround. It's like, oh, you've given me some, you know, substance, and you're tranquilizing me, so it's trying to speed up and sort of get around the chemical. And tolerance develops, and one of the first signs of tolerance happening is the drug doesn't last as long therapeutically as it did when you initially took it. And if you're still just giving it the same dose, which most people do because the doctor just keeps prescribing the same dose every time you go back for follow-up, you're intolerant and you start to develop withdrawal symptoms while you're still on the drug, like in between doses. So before you're due for the next one, you might start getting like severe muscle spasms in your back, like really bad irritability, extreme anxiety, just like terrible physiological withdrawal. But if you don't know that that's classic for this, you know, drug class, you do what I did, which was I attributed it to myself. I thought something is wrong with me.
You're not the only one, though. The doctor does that too, doesn't it? I mean, I feel like that you go and they're like, oh, you know, you're just seeking now. You know, suddenly you're the problem, or you're seeking, and when you're just having
it's one of two things. You were either a drug seeker if you go back asking for a refill, even though this is an expected, you know, thing that this drug class causes. So we should expect that this is going to happen if we keep somebody on for, you know, in some people it happens in a week. It's on the FDA label.
Really?
It can happen quickly. Yeah.
Oh my goodness.
So it's either you are drug seeking, even though you've only taken the medication as prescribed. So there's that language problem again between addiction and physical dependence, where we need to like really know the difference. Right. Or they say it's up, you are either having a worsening of your underlying condition, or you're developing a new so-called mental illness, are usually one of the three paths that the clinician will take, instead of door number 4, which is the right answer, which is the drug you're taking is causing this, and we need to find a safe way to get you off of it.
Right. I don't know why it doesn't even enter the mindset, you know, of the provider when somebody's on a prescription. I mean, some of the things, I guess I really got particularly focused on that when I started doing anesthesia, like looking, because you'd see these long drug lists and you're like, well, but this drug, it causes what you're taking this drug for. Exactly. So are we on this list because of this one drug? Where did this start? You know, I started examining drug lists a lot more as people came to us for anesthesia. So I was like, it was a really obvious pattern, but I don't know that I would have thought that when I was early on practicing as a PA, like, and, you know, grow GYN health or urgent care or anything like that. I don't think I would have thought about it. So it is something that's an important point, and to make for anybody who's a provider, a nurse practitioner, or PA who's listening, because it needs to be on the radar, and there needs to be some gentleness around it too, because it's so quick, it's so easy to blame maybe the patient or go put them in a category, and maybe not blame them, but put them in a category, you know, and then we treat them a little differently. Yeah. And anyway, so that was where you were at with your interdose withdrawal.
Yeah, I was just going to say too, and we have tools, you know, like you can use the, what is it called? The PMP or whatever, to look and see, is your patient just filling the prescription that you prescribed, and they you know, and then so more than likely, I mean, there's a study done by a government agency actually that showed that of benzodiazepine users, I think it was like 1.5% qualified for a substance use disorder diagnosis. So overwhelmingly, people who are having benzodiazepine problems are dealing with physical dependence. It's iatrogenic. Yeah.
And I'm just going to pause just for a second for for the lay people who may not even know what a benzodiazepine is, and just categorize that into names of drugs. Just because I think that sometimes I take it for granted that people know what that is. And so if you're listening, you've never heard the term benzodiazepine, it's a category of drugs that they act in a specific way. And it's typically your Ativans, your Xanax. Those are when somebody says, just take a Xanax. It's jokingly, that's what they're talking about, a benzodiazepine. Am I missing any other?
Klonopin and Valium, Librium. Yeah, there's a whole bunch. They usually end in PAM, PAM at the end, like diazepam, you know.
Yeah. So those are the substances we're talking about specifically on the brain. They can have such a big effect. So, yeah. All right. Sorry for the pause, but I just want to make sure that everybody's on the same page and they're listening and they're going, I don't know what it is. I don't know what a benzodiazepine is, you know? Yeah. So, and I mean, obviously, you can Google it. I'm on this drug. Is this a benzo? Right?
Yeah. But a lot of people don't, too. And that's the problem. They just, you know, we can get into it. But I think that's one of the biggest mistakes I made, was just blindly kind of trusting and not researching, like, what is this drug? What am I taking? What does the FDA pamphlet say about it? You know, all of those things. So, yeah. So I started having adverse drug effects and this interdose withdrawal stuff popping up, but I didn't recognize at the time that it was from the medication. And so that's when I entered the world of psychiatry. I started seeing a psychiatrist because I was concerned, really bad anxiety, agitation. I had some, suicidal ideation popping in, and I was like, what is happening to me,
Was at this point, before that, were you just seeing a primary care, or was it still just a prescription from your colleague, or,
Yeah, just, I mean, it's all kind of, it was so many years ago that it all kind of runs together. And I've seen so many doctors in the process of trying to undo this cobweb that I got caught in, that I can't remember every single, detail. But yeah, I think it was quick after I got prescribed, like 3 months or something. And then I was seeing a psychiatrist. So,
wow. Yeah. Okay. So then you enter the world of psychiatry. That's a whole new world.
Yeah. Yeah. So, enter polypharmacy, which is a lot of what happens because, like I said, most practitioners don't pick door number 4 and they don't identify this new drug you're taking is probably the cause of what you're going through. Let's taper you off of it, bring you back to baseline. Instead, it was, I think you have mental illness, and we need to add more medication. So, over the course of the next 5 years, I saw a psychiatrist who just medicated me into like a chemical soup.
Wow.
And each new drug was to treat the symptoms of the drug prior, very typical, what's called a prescribing cascade. And so by the end of 5 years, I was on Klonopin, which is also a benzo. So I was taking 2 benzos, Xanax and Klonopin. I guess those were so sedating and causing me so much depression that she tried SSRIs and SNRIs, which I reacted poorly to.
How so?
And I just like more agitation, more anxiety. And that's actually pretty common. If you hang out in any of the online support groups for people trying to get off of these medications, one thing that's commonly reported is kind of like once the nervous system is made unstable by exposure to the drugs and tolerance develops, people don't tolerate drugs like they used to anymore. They start having like way more adverse drug effects than they did in their past.
So yeah, even to non-psychiatric medications.
Yes, even like household chemicals, like all kinds of supplements, So
wow. That makes sense.
So when the SSRIs didn't work, she gave me Adderall. And said, oh, sometimes this one like really helps with mood. So now I'm on speed and a tranquilizer at the same time to go back to your saying, like looking at the lists of drugs for your patients. Now I see like so many people are on drug cocktails that make 0 sense at all, and nobody's looking over them saying like, what in the hell is this,
Right. I actually see, because I work in the chronic fatigue space, is kind of the typical, I'm like so fatigued, people come to my clinic, and they've been on, or they've potentially been on a stimulant, which to me, when you put a 30 to 40-year-old woman or man on a stimulant, you're just asking them to have a heart attack, because it's a stimulant, it literally is a stimulant to the nervous system, and it raises blood pressure, and it raises catecholamines, and surprisingly, shockingly, they get anxious. And then the next thing they know, they're getting a prescription for a Xanax. It's the opposite, because they came in with fatigue, and they couldn't concentrate and all this brain fog. And so either one can lead to, prescribing for the symptoms or side effects of the drug, which is, something just for patients to pay attention to, or clients, or you to advocate for yourself. Like, this can happen and it shouldn't. Like, there are other ways.
Yeah. So I also was then put on Remeron for appetite because I started losing a ton of weight because Adderall suppresses your appetite. And then I stopped sleeping because Adderall disrupts your sleep. And so I got Ambien and Seroquel 25 milligrams at bedtime. So I'm on 6 drugs by the end.
All because of counteracting the side effects of the other.
Exactly. And I was sicker than I've ever been. I mean, I don't know how we call that medicine, because you're supposed to make people better. And I just deteriorated more and more over time until I was basically not functioning. Yeah.
And so how did that lead to where you are now? I know so Medicating Normal is the movie that you are involved in, promoting. I think you guys are still offering it. I don't know if you're offering it behind the paywall or not, but I know it caught my attention several years ago. I was excited that you guys were still doing it, because it kind of caught my attention. And I was like, I need to look into that. And I listened to, I think it was a talk that you did on Facebook. And I was like, this is really intriguing. I need to listen to this. And then I don't know, I think we moved 2020. I don't know. But it came back across my feed and I was like, oh my gosh, I really want to connect with this person. So how did, since this is a film that kind of exposes this, all that we're talking about, how did you get involved in the film, and how did you move from being basically unable to function to what you do now?
Yeah. So to kind of wrap up my story, I made a critical mistake once I figured out it was the drugs. My dad is an anesthesiologist, and so he made a living altering people's brain chemistry to put them to sleep, and he recognized in me what was happening. So the biggest mistake I made, aside from ever taking these drugs in the first place, was I went to a detox center because I thought, well, now that I've identified the problem, I need to get them out of my body. If you're taking psychiatric drugs and you're listening to this, do not go to detox. Do not stop taking them abruptly. They have to be tapered incredibly slowly, and you have to listen to your body. Some people take months, other people take years to taper in a way that they can slowly reverse the neuroadaptation that's occurred while you were exposing your system to these medications. And that goes for all of them, not just benzos. Antidepressants cause withdrawal syndromes, antipsychotics, the stimulants can.
Right.
So I detoxed and I developed a horrific withdrawal syndrome. Basically, I think I damaged my brain and my central nervous system coming off so rapidly because I'm about 11 years off of all the medications now, and I still have neurological symptoms. I'm way better than I was in the beginning. I mean, I was rendered bedbound. I had bed sores. I had dreadlocks in my hair from laying in bed for so long. I developed akathisia, which is a movement disorder, which is just horrible. So it was, I don't know how else to say it, but like the worst suffering
I've ever experienced.
Yeah, I can't even put it into words. The people who've been through it know, but if you haven't experienced it, there's just no way to. It's beyond the realm of normal human experience. It was bad.
Oh, I'm so sorry.
So, yeah, I needed to survive that, and I needed purpose. I lost my career, I lost my health. All my friends kind of moved on with their lives and were functioning, and I was kind of holed up in a room waiting for my brain and nervous system to recover. And I didn't have help from mainstream medical care because nobody knew what this was. Nobody believed me. Or when I went to the doctor, they tried to prescribe more psychiatric drugs. And I'm like, I literally I need to heal from this is what's going on. So I've realized pretty quickly that I was going to have to save myself. I was on my own. Luckily, there's a lot of groups online of other patients who are going through this. And so I found lots of friends and support and like valuable information about my condition there. And that's where I also met the filmmakers of Medicating Normal. And they hired me on to help them with marketing and distribution. And, having gone through this and seeing that it's this underground problem that nobody wants to address, I was like, I want to be a part of this because.
Well, I think the part of the problem is you don't want to, we don't want to, take away the trust people have with their physician, but the physician doesn't know, and it's okay not to know as long as you can accept that you don't know and seek to know. Do you know what I mean? Like,
Yeah.
I mean, the best providers, if you don't know something, will seek out the answers. They will seek out and have a humble heart and accept the fact that there's no possible way that 4 years of medical school or 26 months of PA school is going to give you all the information to make all the right decisions for your patient on every drug and every single illness. So I think that it's just this thing where we don't want to make doctors feel bad for what they don't know, but we do need them to know.
Yeah.
You know what I mean?
Yeah.
And we don't want the population to hate their doctor either, but
No.
but
Yeah, it's not about doctor bashing, because honestly, I think they are victims too.
Right.
They are fed a bunch of bad information. There are moneyed interests in keeping them ignorant.
Yeah.
And yeah, I think it's, I forgive the doctors who just don't know better. I didn't know better. I went to PA school and didn't know better. The thing for me that's unforgivable is not being willing to learn and change your position. Like, the best thing you can do is listen to your patients. They typically know what's happening and they're telling you. So listen, they're giving you valuable information. There were so many doctors that I showed up with journal articles about the withdrawal syndromes, and they just wouldn't read them or completely dismissed me. But I did find a psychiatrist who was totally willing to educate herself, and she became like my biggest ally in this. So there are good doctors out there who want to know better and do better. You just have to find them, They really go in hoping to, heal patients. They go in hoping that this is the profession they chose that is going to give them the opportunity to help people. That's why I went to PA school. That's why you went to PA school. That's why a lot of physicians go to medical school. Sometimes they just don't realize that there maybe is a different way, Yeah.
Then.
Yeah. And, we're all humans and guilty of something called cognitive dissonance. Like, nobody wants to believe that everything that they were taught or believed is corrupt in some way, or that they're causing harm. Like, that's a really hard pill to swallow.
Right. I did a podcast on what is the name of I want to say Beauchamp, but Beauchamp is the guy from the terrain theory. It's the guy who really brought hand washing to the forefront. Gosh, what was his name? Austrian doctor. I can't remember. I can't
either.
But he was trashed by his community because they were offended that he would insinuate that the doctors were responsible for puerperal fever, like that was their fault that these mothers were dying after, delivering babies because the doctors didn't wash their hands. And it was offensive, so it's that dissonance that you're talking about. And we don't want to be responsible for harm if our whole identity is surrounded with being somebody who's a healer, but
and on the patients,
ignoring that, we're going to do more harm. So
yep. And on the patient side, I don't think their dissonance, they don't want to know that a doctor can harm them so much. Like, it's way easier to go through life thinking that there's some doctor who can fix everything, But when you break it down and really look, like, medical errors were, like, I think the third leading cause of death in the United States or something. Like, it's not
the number
super
one cause
safe.
of death is prescription overdose.
Yeah.
Number one cause.
It's not super safe to see your doctor. Too much medical care is dangerous. It's a bad thing.
Right.
Yeah.
I agree 100%. Well, I think something that I thought was interesting was that the film highlighted so much that was wrong with the way that we manage mental health, grief and sadness. I think one of the psychiatrists interviewed said that the problem with the approach that we have is that we think that any form of discomfort that someone experiences needs to be alleviated by a drug. And I think it's also kind of an interesting parallel, because I just finished a podcast that's getting ready to release with an author who wrote about her story coming through into sobriety. She was a very functioning person, highly professional and all this, but she used alcohol as a tool to ease her emotional discomfort in the same way that these, we're using drugs, we're using it like nobody should feel any suffering at all. We're gonna give you a pill, or we're gonna drink a bottle of whiskey. Either way, we're easing our discomfort and running away from it. Do you think there's any difference at all, really, between those two, like prescribed drugs and any other form of, easing pain?
Okay,
so like alcohol, cocaine,
yeah, my answer is
meth.
Yes. Yes and no, I think. I'm not an addiction expert, but I think at the root of most of it is, discomfort, or like a desire to escape or not feel pain. And so in that sense, yeah, I think there wasn't much difference between me not wanting to feel anxiety and, maybe someone who's drinking alcohol. There's a great physician out there. For people listening, you should read her work. It's Dr. Joanna Moncrief. She's out of the UK. And she explains how we have a medical model of drugs, which is essentially, she's presenting that it's the wrong one, and that we should have a drug theory, a drug-centered theory of drugs, which is the correct one in her argument. And if you kind of just look at drugs as drugs across the board, saying like, well, what we've done wrong is we've put them in categories, saying like, if the doctor gives you a medicine, it's medicine, it's good, it's helpful, it never harms. But if you get one sort of on the street, or you're self-medicating, then it's bad, it's a drug, it's dangerous, it's harmful. But if you just look at their mechanism of action, they're all kind of similar, and you kind of just choose drugs based on what they do. I mean, alcohol is good for anxiety. So are benzodiazepines. But if you take them long term, all of
your anxiety is going to come back
and tenfold.
Full force. Yeah,
tenfold.
Right.
Yeah.
Right. Yeah.
Where it's different, I think, is there's a concept by a psychiatrist called Dr. Peter Breggin called spellbinding, the spellbinding effect of psychiatric drugs. And he basically describes that people who are taking these medications kind of like slowly lose touch with the fact that they aren't functioning that well. They're actually getting worse. And it's probably because the substance, all the psych drugs, are affecting your brain, the thing that you would use to realize that you're, that's the heartbreaking part. Like, you're altering the motherboard. Yeah. The thing that's supposed to regulate and keep you safe. Like, and know every check and keep you in touch with reality. Yeah. Yeah. So, this happens with psychiatric drugs, and it's reinforced. And here's where the difference between the alcoholic, I think, and the person taking psych drugs comes in, is that when you go to the doctor and you say, I'm drinking away my woes, they don't say in their white coat with position of authority, like, keep drinking. That's a good thing. Or we need to up your dose of alcohol. When you're on psychiatric drugs, though, that is what you're told. We need to give you more. You have this condition that needs treated. You're doing the right thing. And so when I was taking psych meds, benzos that are just basically alcohol in pill form, I thought I was helping myself. It was presented to me in a way that it was treatment for something. Whereas when I drank alcohol or experimented with drugs in college, I knew that I was doing something risky and dangerous, So I think that's kind of where it differs.
Yeah. That brings makes me think of the some of the steps that you guys are taking, and kind of putting a black box warning on some of those drugs, and pushing for legislation to get informed consent to give those drugs. Isn't that what you guys are doing? Or fill me in on some of that.
Yeah, exactly. I mean, the film was not involved in the black box, but there are the film included some of the legislation that the patient advocates are trying to get passed through in some different states. It was passed in Colorado. We're working on Massachusetts, basically to get informed consent, which all we're asking for is that patients are told, or they have to sign something before being prescribed these drugs that alerts them to what can happen with long-term use, so that they can just make an informed choice. We're not trying to take the drugs away from anybody. You know, I'm not in the business of saying what someone should or should not be able to take, because, you know, I want benzos available if I ever need them for something, you know, like a one-off thing or end of life, you know, where they're appropriate. But there are nonprofits that exist that I am working with that advocate, you know, for this type of informed consent and information for the patients. One of them is Benzodiazepine Information Coalition. And like I said, there's tons of support groups out there for people also, you know, going through it.
Yeah, and those links will be in the show notes, so anybody's looking for that doesn't have to pull over on the side of the road and scribble that down. It's going to be available. So, yeah, those are. I'm so glad that you guys are doing that work. I know that you're also involved in the is it your nonprofit, the Withdrawal Project, that kind of covers more than just the benzos, or?
Yeah, so I co-founded the Withdrawal Project, which is basically there's a companion guide there that we wrote with input from doctors, pharmacists, you know, people who are educated on psychiatric drug withdrawal, and patient advocates, of course, because honestly, they know more than most physicians because they've gone through it. And when you're stuck on a drug and you have to get off of it and your doctor doesn't know how, the patients, I mean, some of them are brilliant with the ways that they've come up with to get themselves safely off of medication. So we took all that information and put it in a really kind of user-friendly companion guide for discontinuing psychiatric drugs of all kinds.
That's amazing. That's wonderful.
Teach people how to be your own best advocate. I mean, obviously having a doctor on board is important because you're going to need the prescription medication in order to taper it. You have to have the drug. But some people, unfortunately, don't have a doctor who knows how to do it. And so they learn and they do it themselves, you know?
That's amazing. Yeah. And I always say that the best doctor is you. If you have the tools to advocate for yourself, the best doctor is you. You are the one experiencing the symptoms. It's you who knows when you take X, Y, and Z that this is the response I have. And it's you that can speak up for that and maybe seek help from somebody, or maybe make a different direction or ask the right question. You know, it's you. You know your body better than your physician does. You don't fit into a mold. And what I love in my practice is that I don't put people in molds. Everybody's very, very unique. Everybody's got a unique set of issues and root cause problems, and we try to work with that specific uniqueness in our treatment protocols. And I kind of want to shift gears a little bit, but in that same vein, because this podcast is it's a brain health podcast. It's really geared to help motivated people who want to know how to biohack their brains and their health, really to prevent dementia, because dementia is a big thing. It's outrageously increasing. It was a thing of before the early 1990s, like late 1980s, it was very rare that somebody truly had dementia, like truly had it. It was not a very common diagnosis. Now it's extremely common. Every other person has dementia, and it's a problem that's affecting people at younger ages. We're talking about 30 to 64, people are being diagnosed with dementia. So I know that a lot of people who tune in here are interested in protecting their brain long term. And so I want to kind of ask you, like, if you know, and I didn't have the time to research, I saw there's tons of research about the impacts of benzos and the psychiatric medications in the short term. Do you know of anything in the chronic effects of benzos long term?
Yeah, so they have researched, and as far as I know, the dementia argument is still out. There's lots of papers saying, oh, there's a link here. And then there's lots of papers saying, we didn't really see a link. And so people are kind of still arguing in the literature about that. Now, I don't know how good the studies were. That's another point that people have to sort of learn how to discern, like, what's a good study.
How to read the good studies. Yeah.
Exactly.
Seriously, it's really that bad.
Yeah. I think the verdict is out on that still. But even the fact that people are questioning, I can just say benzos were incredibly damaging to my brain and the brains of many, many thousands and thousands of other people that I've talked to who took them, as far as cognition, memory. It destroyed my sleep. And sleep is fundamental. Okay, so let's just say if it destroys your sleep, we do know that a lack of sleep causes dementia. We know that. That's been proven. That's in the medical literature. That doesn't even have to be a holistic doctor telling you that. I mean, I remember a study that came out just after I finished PA school, like 2007 or something, and it was talking about sleep apnea and how it's linked to dementia and stroke. And the reason was pathophysiologically because it disrupts your sleep. So we know that anything that disrupts your sleep can absolutely have an impact on your brain. Yes. And there's actually a physician, Dr. Daniel Kripke, Kripke, who has done research on sleeping pills like Ambien, Lunesta. Those are called non-benzodiazepines, or Z drugs, but they're incredibly similar in their mechanism of action to benzodiazepines. So actually, when you read about how to taper benzos, there's a whole section in there about Ambien too, because the withdrawal is so similar. And anyway, Daniel Kripke made his career on studying those, and he's put out tons of papers about them, about how they increase the risk of cancer and other problems because of, essentially the lack of sleep, that they disrupt your natural sleeping. Even though you think you're sleeping, you're not tranquil. You're not going into REM, essentially.
Right. The thing I thought was really interesting when I was kind of reading about alcohol, and since benzos and alcohol they're so similar, is that alcohol actually stimulates you to a more, you feel sleepy, but you actually hit alpha waves, which is the alertness. Your brain waves actually go into a wave that is a more alert wave. So when you go to sleep, you're actually awake. It's like a crazy, and I think that's probably, I'd love to see studies on how benzos work, but that's just a theory on my end.
There's a chapter in a book called Why We Sleep. I forget who the author is, but it's a great book. Anyways, the whole chapter is summarizing like what benzos and sleeping pills do to our sleep. And there's a lot of citations of Dr. Kripke's work in there and all the harm, they can cause. So, you can find just like a short version of it in that book if you're looking for the information. Yeah.
Well, that's awesome. I thought it was also interesting. I went on to the, the Benzo Coalition website.
Benzodiazepine Information Coalition. You can call us BIC for short.
BIC. Yeah. I liked all the research that they provided, and there was research that went all the way back to the 80s and showing essentially the ineffectiveness of Xanax. It was like compared to placebo, like at the 8-week, like 8-week point, that they were less effective or actually worsened anxiety. Wasn't that something like that?
Yeah, that study was actually done by the pharmaceutical companies, I believe, and it's in the film where there's a big, infographic that explains the study. But essentially, what they did was they in the study it revealed that at I think it was 14 weeks, people were far worse who were on Xanax than their non-drugged counterparts. But they were better in the very beginning. So what they did was they only reported the early success in the abstracts and everything. And so it was, told to the world that Xanax is this effective treatment when it really, the study showed that it was harmful.
Yeah. The biggest concern and one of the things that makes me really want to speak up loudly on this topic is the fact that it's being prescribed at younger and younger ages. I mean, like, I was looking it up. I just couldn't get over it. It was 10% of children are being prescribed antipsychotic medications. 10%. A third of all kids 12 to 18 are on an antidepressant. A third. That's a lot. 43% of people, young adults 19 to 21, are on them. That's almost half. That's an epidemic. That's a problem. And it's particularly close to home for me because I have, when I finished PA school, I had a child, and then I had another one, but the one that I had that was a baby, basically, he was 2 when I graduated PA school. He was very, very ADHD, and he had he was ADHD. He was very, very busy. Now I work with brain health. I know that ADHD, I can really change direction very, very quickly with environmental changes and very specific supplementation. But I looked back then. I looked for something that was like anything. Give me something that I can give my child besides what I was taught in PA school, because I don't like those drugs. I don't like what they say. I don't like the impact. I don't want to give them. But all the evidence-based medicine reports were like, wow, that stuff doesn't really work. And, gold standard is a stimulant. So we had him taken to a psychiatrist at 4.
Wow.
He was diagnosed with ADHD at 4.5, and he was prescribed a stimulant. And we went through them. We went through all of them. Like, he ended up finally settling at Vyvanse after losing weight, drooling, being catatonic, all the things at such a young age. And I remember thinking, this can't be good for his brain, but I don't know what else to do. Like, my evidence-based medicine says this is the best we have, and the doctor says it's okay to give it to him at this age. So I guess, well, fast forward a few years, and he was on Prozac because he was having side effects at age 8. And then fast forward a few more years, and I had started to peel back some layers, and I was starting to open up my understanding into holistic health and going into a lot more research in the natural health world. And I realized that there are options. I found them finally, after he'd been on medications for almost 7 years. And so I approached him because now he's a adolescent, and he, I said, I'd really like to get you off of these medications, and but I know that they help you concentrate. And I'm telling you, like, he was the classic that if he took his medications, he would write neatly, he would answer every question correctly, he would do his school so clean. If you took him off the next day, it looked like a toddler did his schoolwork. It was insane. It was just night and day. And so I wanted his involvement in it. Now, of course, I didn't fully know how to do it, but I knew he needed to come off of them. And ultimately, when he started to notice girls, he was like, yeah, so I'm not gaining any weight, so can I come off my meds? So at that point, we finally did. One of the things that was concerning for me was when he was medicated. When the medicine would wear off, which was around 3 or 4 in the afternoon, he would have almost a rebound, like way worse. It was way worse than baseline ADHD and impulsivity. Like, the impulsivity was through the roof. This was a very smart child. He's a very smart kid. And I'd find him in the back of the corner playing with matches in the house at age 10. Like, he knew not to do that, right? So it was like this kind of impulsivity that made no sense. And so he finally came off of the medications slowly. And we did all the things, diet and all the things. And he's fully functioning now, 10 years later, doing just fine. But there was about a year into it after coming off. We caught this kid in a bold-faced lie, like a bold-faced lie. And he's not a kid that lies. So we were like, and it was an obviously, like a really, really obvious lie. Why would you lie about something? And it was something about something really dumb, not even something worth lying about. And so my husband and I were both very confused. We're looking at each other like, what? Why did he lie about something so stupid? Why would he waste punishment?
Yeah.
So I finally gave it a day to calm down. I asked him about it. And now this kid was kind of 13 years old at the time. He wasn't, certainly not abstract thinking about the world around him or anything. But I said, well, would you please tell me why you would lie about something so dumb? We caught you in that lie yesterday. Why would you do that? And he said, the inside of this statement, I want everybody just to pause and listen to this. This was a 13-year-old boy telling me his experience. He said, well, Mama, do you remember when I used to, tear stuff up, a couple years ago and light the matches and do stupid stuff like that? I was like, oh, yeah, I remember I got turned gray during that time. And he said, yeah, well, I knew it was wrong, but I didn't care. And I was like, huh, okay. And he said, I wanted to know, because I was feeling different. I wanted to know if I lied, if I felt bad about it. I said, now. So it was like, now I wanted to know. I said, so did you? And he was like, yeah, I felt really bad about it. So
yeah.
What it highlighted for me was just this amazing, was it maybe that depersonalization that you were talking about when we talked earlier this week? Like just to disconnect, like with what he knew was wrong, but he didn't feel about anything about it. He didn't feel like it blunted his total effect. Those were the medications that he was on. That's the first thing I went to. I was like, the only difference between now and then was that now he's not medicated.
Yeah.
So pretty profound.
That's how some of the drugs work. We've been fed this lie, this chemical imbalance theory that the drugs are correcting some chemical imbalance. And that has since been disproven. Mm-hmm. So if anyone listening was told that and still believes it, there is no, proof that there's a chemical imbalance and that the drug comes in and goes right to the imbalance and rebalances it. No.
Right.
The antidepressants are thought to work by some experts by numbing. That's what they do, is they suppress, they numb. And in the withdrawal syndromes too, the dissociation, the depersonalization, the derealization, you can feel completely numb and disconnected. And so now you were talking about the numbers of people that are taking these medications. I mean, what is the cost of having so many numb people in our society, who can't care or who don't care? It's marriages lost, friendships destroyed, all kinds. If you just extrapolate it out, it's huge. And there's we're not better for this. If you look at like the rates of mental illness, since the introduction of medications, it's gone up, not down. And there's a book about that. It's called Anatomy of an Epidemic by Robert Whitaker, and he examines that very thing. Well, if the drugs are working and they're so great, surely we should see it in the numbers that it's actually... We
should have a utopian society.
Yes, and that's not what he found. Spoiler. So, yeah.
Wow. Yeah, and that goes back to the whole thing that was highlighted. I really paid attention to in the movie, that that psychiatrist is saying, like, what we used to do for people with grief is walk with them. We would walk with them. We would give them a space to talk. We would do talk therapy. We would hold their hand. We would grieve with them. But now we're just medicating them, and it's an easy and it's a depersonalized way to handle what is a normal response. PTSD, which was highlighted in that movie a lot, that was another one close to home for me. My family, I have family members who are military and absolutely have PTSD. And never took medications, praise the Lord. But, you have to grieve with them. You have to let them process that, what they experienced, which is hard and that most people don't experience. And I just think it's a pretty impersonalized way. It's a little less humane, a little less intimate to just give people medications.
Yeah.
Well,
it's multifaceted how we got here. Like, we have 10 minutes in a doctor's office. You can't possibly help somebody in the way that you're talking about in 10 minutes. And so medications are quick and easy and they just get the patient out the door. But it doesn't solve the problem. It's Band-Aid. So many people who I interact with all the time who come off the meds say, like, all I did was kick the can down the road. Like, the problem's still there once I get off the drugs. I didn't deal with it, And I also think about things from just a basic perspective of, like, if we're not meant to grieve or feel discomfort, why does our body do it? It's obviously, like, the way that we're designed. And so we're suppressing some natural thing that's probably part of the healing process,
Oh, yeah.
Every once in a while, I'm surprised. Like, I interact with somebody and on the note of grief, I somehow was connected with somebody at a grief center at, like, some major hospital in the US. And I can't remember which one. I wish I could, but they said, I don't accept patients for our grief program who are medicated because we can't treat them. They're numb. They can't feel the feelings that they need to feel in order to get through the grief work that we do. That's really interesting.
That is interesting. One of the things I tell my clients that I'm working with, because a lot of times they have, underlying maybe chronic infections or something like that, is that when we start to clear a lot of the issues physically, that will result in an emotional response. And so I will prepare them that you may experience grief, and it may be from something that you didn't expect. So as your body heals, my point is that as your emotions in your body are connected, they're not separate things. And, physical pain can lead to grief, and grief can lead to physical pain. And the healing process is intertwined with emotion. And numbing either of those is not the answer. Yeah.
Yeah. People, psychiatry likes to think like that we're divided. We have a head and a body, but that's not, it's like when I had a breakup in college and I broke out in hives from head to toe, that was emotion causing physical symptoms.
Right. Yeah. Exactly. Well, I think it's wonderful what you're doing. I'm glad that you're out there and advocating for patients and really educating medical providers. I came away with more information from the movie, from listening, reading through the advocacy blogs that you sent, and just talking to you. It's been really helpful. So I just want to ask if there's any last things that you want to encourage, people to do, or any kind of advice you have that you want to leave the audience with.
Yeah. I think just to circle back, when you asked me or reached out to me and asked if I wanted to come on and chat with you, I was poking around on your page and stuff and saw that your tagline is "the best doctor is you." And I was like, okay, I'm going to talk to her, because I think looking back in my own story, the mistake I made, the biggest regret I had, was giving away my agency to somebody else, a physician, just walking in and being like, fix me, as if I didn't have any part in the decision making or the research or, and some of that was kind of, I guess, trained into me in PA school.
Yeah.
They say to you, like, don't be your own doctor,
They
and
do.
yeah.
I think I remember the quote that they gave us was the father of PA school. What's his name? They said, gosh, now I can't remember the doctor's name. It's going to drive me crazy. But
okay.
he was the person who is his own physician has a fool for a doctor or something like that. And it's a famous quote by a physician. And essentially, I remember that same thing was kind of driven home to me, like, the doctor knows better, evidence-based medicine, yada, yada, yada. But I find that when people are engaged, like, you shouldn't check. You're going to ask your mechanic about your car.
Oh, certainly.
He's going to give you a laundry list, and you're going to go, well, wait a minute. Blah, 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 blah. Aren't we're way more important than our, Ford, that we're sitting in the car. We're more valuable. We should absolutely be engaged. I think sometimes when people become parents, maybe they start to see, oh my gosh, wait a minute. This is not, when it's not themselves, but it's somebody they love, they're like, wait a minute, I need to ask a question. Yeah. But it's really important that you engage your own health, because it's yours. And when it's gone, you said something really good in our conversation last time, and you said, you don't have your health, you don't have anything.
You have nothing. When I got sick from this, I had nothing. It was all gone, just stripped down bare to you yourself in a room with nothing. Mm-hmm. And that it was like a profound lesson for me. Like, holy crap, I have one body, I have to care for it. Mm-hmm. And, I became this, like, I just learned everything I could learn about healing myself and eating properly and exercise and, like, all the things I wish we would teach young people, like I said in the beginning, about, like, how important it is to be healthy and care for yourself, because when it's gone, you have nothing.
Yeah, I wish that was part of the pediatric education model. Like, okay, you're going to go home, you're doing your annual checkup. Here are the things that you lifestyle things that we need to do. Like, here are the lifestyle approaches we do at 13, that we start giving them some guidance and letting them take some ownership and and just reiterating that at every annual follow-up. That would be more valuable than your heart and lungs, everything's good, you're right on track, give us some tools.
And it sounds so, some people are like, oh, that's woo-woo and whatever, but it's not. I mean, it takes work. Most things worth having take work, but just even when I changed my diet, I stopped biting my fingernails for the first time in my life. Like, these things do impact your mental health, Think about how, like, agitated and whatever you get when you haven't eaten, and then tell me, like, your diet doesn't affect your mood. Right. It's all,
Good point.
Yeah.
That's such a true statement right there.
Yeah.
Yeah.
So I guess for patients, advocate for yourself. You can fire your doctor if it's not working, and you can research and find another one.
That's right.
For people looking to get off psychiatric drugs, our nonprofits, we have a list of physicians who are educated and can help with psychiatric drug withdrawal. Mm-hmm. And then I guess my take-home stuff for, medical people who are listening is, believe your patients, listen to them, be willing to learn something new and read what they're presenting to you. Mm-hmm. And look at those medication lists, that you and I were talking about in this conversation, and ask. I mean, even just ask the patient, are these working? Like, do you feel better? Because sometimes they're like, no, I'm not, I don't even, and then start examining, like, how is this polypharmacy affecting this person? And would they be better if we could get them off some of this stuff slowly and, over time, and see, like, where are you at on 3 drugs instead of 8, know?
Yeah. Right.
Yeah.
That's so true. That was a perfect way to finish our conversation. I just want to make sure everybody checks out the film Medicating Normal. And how do we get it?
It's basically on any platform you can think of. Just go searching for it. And by the time this is up, I think you should be able to watch it on YouTube for free as well. Yes. So
free is always good.
Yeah.
I love
It's
that.
been behind a paywall for a long time, but that's just how films are distributed. Yeah. It takes time to be free. So,
and it's not a long film, but it is an intriguing, captivating, definitely relevant. It's so helpful. I think if you watch it and you don't have have an issue with benzos, you can think of 3 people. I did when I was watching it. I was like, I need this to this person, that person, and this person. They need to hear this.
And it's not just benzos, it's antidepressants, it's stimulants. I mean, the film is about all psychiatric drugs because they all can. They can all harm. Yeah. And we're just now finishing up all of the foreign language versions. So those are coming soon for anybody who needs it in other languages as well.
Oh, okay. That's really helpful. And as always, the links to the Withdrawal Project, BIC, Benzodiazepine Information Coalition, and even the Benzodiazepine Action Work Group of Colorado, that all those links will be in the show notes so people can find them, so it's easy to access. Thank you so much for joining me. It's a really great talk, I think, really relevant, and I hope that it gives people some hope and empowers them to be their own best doctor.
Agree. Right? Thanks so much for having me and for the work that you do. It's really important. So
yeah, thank you. All right, talk to you soon.
Okay, bye-bye.
My hope is that this podcast has left you with a few new insights, hopefully some encouragement, and most importantly, some actionable steps forward toward healing your body and your brain. If you found this content helpful, please don't forget to give us a like and share it with someone else who might benefit from it. Also, don't forget to follow us on our Instagram and Facebook pages. I love hearing from you guys. I look forward to spending some time with you again soon. So until then, celebrate the small victories. There really is hope for lasting healing.